welcome to Put Into Practice, the podcast for the HCO Oncology Practice. I'm Dr. Fumiko Chino, an associate professor in radiation oncology at MD Anderson Cancer Center with a research focus on access, affordability, and equity. In 2024, the U.S. Department of Justice initiated rulemaking to reschedule cannabis from Schedule 1 to Schedule 3 of the Controlled Substances Act. Currently, 40 states allow medical use, and 24 states have legalized recreational use. High-quality research into cannabis, however, continues to be outpaced by public interest in the drug as a treatment for a range of symptoms relevant to cancer survivors, including sleep, anxiety, appetite, and pain. I'm happy to welcome two guests today to discuss new research highlighting national data regarding cannabis use in cancer survivors. Dr. Timothy Pawlik, MD, PhD, MPH, MTS, MBA, is the Surgeon-in-Chief of the Ohio State University Wexner Medical Center, Chair of the Department of Surgery, and the Urban and Shelley Mayer Chair of Cancer Research, and a professor in surgical oncology at OSU. His prodigious body of research focuses on staging and treatment of gastrointestinal cancers, medical ethics, patient and provider communication, and gaps in high-quality cancer care delivery. He is the senior author of the manuscript, Patterns of Cannabis Use Among Cancer Survivors, Insights from the Behavioral Risk Factor Surveillance System, which is featured in JCO OP's April print issue. Chia-Yi Joey Tan, LM SWC, is an Innovation Fellow at the Penn Center for Cancer Care Innovation and a doctoral student at the School of Social Policy and Practice at the University of Pennsylvania. She is also a social work fellow within the Leadership Education in Adolescent Health program at CHOP. Her dissertation proposal explores how mental health, coping strategies, and patient-clinician communication shape cannabis use behaviors. Her background as a clinical social worker and cancer survivor informs her research focused on adolescent and young adult, or AYA, cancer survivors. Our full disclosures are available in the transcript of this episode, and we've already agreed to go by our first names for the podcast today. Tim and Joey, it's so nice to speak to you.
Thank you so much, Fumiko.
Thank you.
Before we dig into the specific research, do you mind taking just a bit of time to discuss your background and research focus? So, for example, I know during residency, you completed a Master's of Theological Studies focused on bioethics, and during your early career, you finished your PhD in public health and an executive MBA. So I think it's clear from your incredible body of research also that these are just not decorative degrees. Do you mind discussing how your career has developed over time and how your focus on fostering the dual goals of cancer innovation and patient-centered care has led you to your current leadership positions at the James, at JAMA Surgery, et cetera, et cetera, et cetera?
Yeah, thanks so much, Fumiko. So I think for me, I'm just inherently a curious person. And so with cancer patients, it's so multidimensional. And part of my career has just been trying to look at all the different dimensions of cancer care. Part of that is delivery of care as a surgeon, with a knife and a bovie and using the operating room. Part of that delivery of care is, holistic care around spiritual needs, religious needs. Part of that care is some of the work we do now. I work with a clinical psychologist, Dr. Liz Palmer, looking at shared decision-making and antecedents to how patients approach big decisions about therapeutic choices. And then part of that is about the business of medicine and how can we more effectively and efficiently deliver care that is more equitable and accessible for all patients. So I think that's been the arc of my educational journey, is trying to get different tools in my toolbox to look at the different aspects of cancer care. The one thing that has always been consistent, however, is it is always patient-centered. It's always focused on the patient and how we can help patients have a better clinical outcome, have a better personal outcome, have a better spiritual outcome, and also better care delivery of cancer services for everyone in need of them.
I have to say I was really impressed in terms of your body of work about the diversity of even co-authors that you've worked with. You mentioned just now, working with psychologists, psychiatrists, you share decision-making, we have surgeons, you have medical oncologists. So it seems like you've been not just collecting degrees, but also this incredible research team.
Absolutely. I mean, I think if you want to run fast, you run alone. If you want to run far, you run together. And I also think that I truly believe in this diversity of thought. I know what I know. What I'm striving to constantly do is to get outside of my discipline and be exposed to other people who have different methodologic approaches, different life perspectives, and different techniques that they're bringing to bear into their research so that we can work collaboratively and creatively. And much of creation is this the admixture of different thoughts in different areas. And so that's what I've really strived to do. And I've been very, very lucky to have a wonderful group of collaborators over the last 10 to 20 years.
Yes, it's impressive. I feel like your body of work really embodies like this whole team science idea, which is like multidisciplinary, collaborative, really trying to learn from as many disciplines as possible to make sure we're actually optimizing patient cares in so many dimensions from diagnosis all the way to end of life.
That's the reason why many of us went into cancer, because it is such a team sport, right? Where you're working with med-onc, rad-onc, you're working with social workers, you're working with clinical psychologists. And we know that to be successful in cancer, the only way that it's possible is to do it in a team-based approach. And I think that all of us here on this podcast today and all of us in this discipline, I think, embrace that and acknowledge that.
Yeah, we should not be territorial about our patients, certainly, but also about research ideas and how to actually like explore them well. Shifting to Joey, I know your PhD focus is on developing mental health interventions to promote long term cancer survivorship outcomes. And it's informed by your own background as a cancer survivor, but also as a clinical social worker, a prior research coordinator. Do you mind sharing a bit about your journey and then specifically how you actually got interested in cannabis as a focus?
Yeah, definitely. So, as you've mentioned, part of my identity includes being a child cancer survivor. When I think back to the day when I was diagnosed with cancer, I remember my first thought that came to my mind was, am I going to die? And even though my oncology team and parents reassured me of my prognosis, it still felt very scary. As an early adolescent, I did not imagine having to think about death or adjusting to cancer. I eventually met two other cancer survivors who I closely bonded with. Many times, we share our mental health struggles together, knowing that the three of us could relate to each other, sit through the pain, or lift each other up. I share this story because I want to emphasize that mental health was kind of a thing that was not emphasized back then. Because of this, I was determined to address the psychological well being of adolescent and young adult cancer survivors, which I'll refer to as AYA from now onwards. I went on and obtained a psychology degree from San Jose State University. I met my mentor there, Dr. Jennifer Gregg, and she encouraged me to dive into a topic I was interested in. And this led me to pursue a Master of Social Work degree at the University of Michigan. And during my time there, I was fortunate again to be mentored by Dr. Brett Zebrak, Dr. Nao Zhang, and Dr. Nina Francis Levin. And so all of them gave me a great foundational training in AY psychosocial oncology training. After graduation, I joined a research lab at Michigan Medicine, led by Dr. Erin Bonar and Dr. Maureen Watson. Their research focused on designing interventions to address substance use in young adults, as well as evaluating it. In one of the studies that I coordinated, we found out that those who received our Snapchat-based motivational interviewing intervention had shown a decrease in their heavy alcohol use, and at the same time, their mental health did improve. And so while participants in this study was not cancer survivors, it made me curious to learn whether or not substance use is just another understudied topic within the AY oncology population. So to explore this inquiry, I applied to a few PhD programs, and I got accepted into a social welfare program at the University of Pennsylvania. And so right now I'm being mentored by Dr. Meredith Doherty, as well as Dr. Lisa Schwartz, where I'm able to dig deeper into the topic of cannabis use in AY cancer survivors. And to prepare for my dissertation, I had to synthesize some literature together. And what I know that is that based on the data provided by other researchers, as well as national databases, it's that cannabis use is rising within the general population, especially in young adults. So there's not a lot of primary data research done with the cancer population, and I decided that this is the population I kind of want to explore more.
Thank you for that summary. And it's taking your lived experience and then thinking about how do I actually work together within, again, a team of people to both educate myself, but also foster this environment of learning so that we can actually explore and address some of the issues that you faced, which is mental health is a big concern. And especially if you have a long-term survivorship, hopefully decades of life, it's not something that we can just push under the rug, right? It's front and foremost, and unfortunately affects you on a day-to-day basis. So I really appreciate that commitment to paying back.
Yeah.
Now, Tim, do you mind walking us through your JCOP study, what you did, what you found, why it matters?
Yeah, sure. So, like most good ideas, it came from the clinic, having patients who asked about cannabis use as part of their cancer care. And then also, as you highlighted, given the new reclassification of cannabis and the increased legalization, we thought this was a topical subject within the cancer field. So, this is a study that used the behavioral risk factor surveillance system, which is a state level telephone survey administered by the CDC. And the survey consists of different modules, one of which is the cannabis module. And it has self reported information on health risk behaviors and chronic conditions such as cancer. And so we use this database to define factors that were associated with cannabis use among cancer survivors. We looked at over 6 million patients. Most who were female tended to be a little bit older. So, to Joey's point, this was a population a little bit older. It wasn't a younger population. But even in this older population, 1 in 12 patients self reported cannabis usage. And it was interesting that, there was roughly an equal proportion of patients who reported low versus high usage, which was defined as 20 or more times per month. Again, to Joey's point, the usage of cannabis was higher in younger individuals than older individuals and was also more common among male patients versus female patients. And then the other thing that was interesting was that half of the patients reported that they were using it for recreational use, not necessarily because of their cancer symptoms. So we can see that the usage of cannabis is increasing generally across the population. And that means even among cancer survivors. Yet we shouldn't believe that all of that increased usage among cancer survivors is for symptom treatment. It is just generally trending with the overall population. And then finally, perhaps not surprisingly, state level legalization of cannabis was associated with increasing cannabis use over time in those states where it was legalized. Now, obviously, the study has several limitations. It's a retrospective cross-sectional analysis. So, one should not infer causation from such a study, but I think it does provide some important data to frame the context of cannabis use in the cancer survivor population.
You brought up something from the very beginning. This kind of came out from a clinically relevant topic, like you're seeing it in your clinic. And so I guess my follow-up question is, how are patients coming to you as a GI surgeon about their questions for cannabis? Are they asking you about its use for symptoms or for cure, or if it's safe to use, or is it just like every variety of question that you get?
Most of the time, it'd be rare to relate it to cure. Most questions surround, I am a cannabis user. Is this a problem? Is this going to have effects with my therapy? And or I am having pain or poor appetite. Would being started on cannabis help with that? Interestingly, we're publishing another paper that's going to be coming out in the next couple of weeks where we specifically looked at whether early prescribing of cannabis was associated with reductions in opioid usage, and it was not. It was not. So patients who were prescribed cannabis early on did not have any difference in their morphine equivalents with regards to their opioid usage. It really was more associated with certain diagnoses like pancreatic cancer, and then also certain subsets, demographic factors like younger age and being a male.
Oh, that's super interesting research because certainly I know, at least from research that I've done in the cannabis space, that patients do use it for all sorts of symptoms, including things like pain. So, again, we'll look forward to your paper coming out about those kind of long term outcomes in terms of opioid sparing. I know, again, the minority of people at this point that has been asked about it are using it for cancer cure, thankfully, because obviously there is no evidence for that. Now, Joey, shifting over to you, do any of these findings surprise you, 1 in 12? are using cannabis products. What does your research and or your lived experience within AYA community say about the current knowns and unknowns about cannabis use in cancer survivors? So are we over or underreporting the issue? And how does this knowledge contribute to kind of what I consider the growing communication gap about cannabis use in survivors?
These findings definitely did surprise me in some ways, and in some other ways, it was really similar to what's out there. So for the prevalence rate, it was really nice to just see a refresher to previous studies because there's some caveats to consider as well. For example, the legalization piece, there's a study recently published that looked at the Washington area. And so researchers surveyed about 1,500 adult cancer survivors and found that 28% actually reported current cannabis use. So it definitely does speak to how legalization might influence cannabis use. And then with young adults, we do know that they actually do engage in cannabis use at a higher rate. What did surprise me was the binge drinking rate as well, that there was some co-use. And so that's kind of a very exciting area to explore whether there might be other substances to consider when thinking about cannabis use. On another note, I've done some work with Dr. Catherine Wilsnack. Her dissertation focuses on how cancer survivors engage in cannabis use and other substances. And so I did some qualitative work with her. There was a common theme about mental health and cannabis use in her work. She generously allowed me to share some of her findings in this podcast today. As reported in this issue, worsening mental health is associated with cannabis use. And in her study, many of them shared that they use cannabis to dull their emotions, deal with anxiety, take the edge off, and one felt that they depended on cannabis to escape and to feel numb. Similarly, some others say that it was better to be high than to face their reality. And so as we think about cancer, it's a really tough experience. And we're not just talking about post-diagnosis, we're talking about during treatment and after the active treatment. For cancer survivors, there's so many physical, social, and mental health aspects that influence their physical well-being. So you can tell that cancer survivors are really struggling, and that's the use of cannabis is one thing that they're really using just to cope at some point. And there's just still so much unknown about cannabis, such as the modality. So it's amazing that we are starting to work in cannabis, but there's just so much more to explore, such as how are they really using it? Are they vaping, smoking? Are they dabbing edibles? When you're measuring them, it's so tricky to figure out how much they're really using. I say this because one of the cancer survivors in her study mentioned that when they actually use cannabis, it made them lose their appetite. And that's a kind of counterintuitive because that's what a lot of cancer survivors are using cannabis for. And so we have to think about tolerance level, the type of cannabis strain. Is it THC, CBD? What kind of THC strain is it? And so there's definitely a lot of work to be done here.
Just as a follow-up question, do you see discussions of cannabis happening, if you feel comfortable sharing, in the AY survivorship closed communities, the Facebook groups, the chats, the whatever, the WhatsApp conversations? Is this something that you feel like you're kind of seeing again and again?
Not so much about cannabis in general, but for some of them, like one person that mentioned, they just felt that they should not be talking about cannabis as much because they're like, I survived, and how can I just tell people that I'm smoking cannabis? Because smoking is bad, and so I feel guilty for that.
So there's still some maybe shame and also restriction around it, having the broader conversation.
Mm-hmm.
It was helpful to know. Now, Tim, a recent small randomized controlled pilot trial for patients with pancreatic cancer, which again, I know is in your GI space, was recently published in OP. It found numerically better, but not statistically significant improvements in symptoms. This kind of adds to some research about maybe cannabis being helpful for nausea. And additionally, I know your own analysis from 2024 from NIS data shows that actually cannabis use disorder doesn't appear to be associated, thankfully, with any worse surgical outcomes for patients undergoing complex cancer surgeries. But clearly, obviously, there's controversy about cannabis use. So what are the concerns that you have as a provider and then also as a health system leader about the use of cannabis in people with cancer? Obviously, again, your study in OP showed that there's an association with some negative health factors like binge drinking and cigarette smoking.
Yeah, absolutely. Actually, we just wrote an editorial for ASCO Daily on some of the downsides of cannabis use amongst cancer survivors. And, as Joey mentioned, up to 70% of cannabis users will inhale it via smoking or vaping, and that can elevate the risk of respiratory disorders like asthma, early onset COPD, especially amongst younger individuals. And cannabis has been shown to have some immunomodulatory effects that may change the inflammation in the lung and even hyperresponsiveness, as well as bronchodilation. And there's even been some data that suggests that it can affect the tumor microenvironment in the lungs and have an impact on CD8 cells and natural killer cells. And in addition to some of the pulmonary downsides, there's also some evidence around cardiovascular disease with regards to stroke, heart attack, elevated cardiac output, and things like that. So I think right now there is some concerns around this, and the American Society of Cancer Oncology actually advises to avoid high dose cannabinoids and derivatives for cancer survivors. I think the other thing that's interesting to me also is just the source of the cannabis acquisition, because there's medical dispensaries where there's a certain quality, if you will, to the cannabis. And then there is other means by which people can be obtaining it. And even maybe up to a third of patients may obtain it from a non-commercial source, like peer sharing or on the street or even growing it at home. And this can expose patients to byproducts and impurities, and especially in communities that have high social vulnerability, this could really heighten their risk for adverse effects. So I think we got to keep that in mind also when we're talking with patients about cannabis use. Where are they obtaining it and what is the quality of the product?
Absolutely. And my own research shows that patients are paying a lot for this for a single drug. The median person, at least that we surveyed, that was paying $80 per month for cannabis use, which is, if you think of it as a drug cost, is actually quite expensive. It could push out other needs that they have of food, transportation. It contributes to financial toxicity too. Joey, ASCO released a guideline on the use of cannabis and cannabinoids in adults with cancer, and JCOP published a very helpful Q&A about the guidelines in 2024. The guidelines recommend that clinicians should routinely and non-judgmentally inquire about cannabis use and either help guide care or direct patients to appropriate resources. Do you mind sharing anything from your research that you found out already about how to improve effective communication about cannabis to patients?
Yeah, so this is great and timely guideline that's provided. I will say that that's not something I can confidently answer right now, just because it's something that is in the work. Part of my dissertation includes exploring the perceived impact of patient-clinician communication surrounding cannabis use among young adult cancer survivors, as well as their communication preferences. I am trying to start my recruitment, which will start in a few months. So I'll hopefully have better answers for you by then. But on another note, I do want to share some insight from Dr. Will Snack, these dissertation data, just to share with you how cancer survivors have felt about their communication experiences. So for some cancer survivors, disclosing or discussing their cannabis use did not influence anything at all. In fact, some clinicians actually did encourage their use. And I do want to say that it's different clinicians, so primary care or oncologists, there's somewhat of a difference there. I do recall one person saying that they actually felt more comfortable talking about it with their primary care than their oncologist. And for some other cancer survivors, they felt that it did impact their relationship when they disclosed their cannabis use with their oncologist. And others also did feel like it was embarrassing to share about their use. So at the end of the day, I think it is ultimately up to cancer survivors to disclose their use, but it's also helpful to try and understand how cancer survivors are feeling about their own cannabis use. There was one survivor who shared that they knew that it was not good for them, but they still chose to do it. And another felt that they were disappointed because they engaged in cannabis use. So there's really this sense of shame or even self-stigma at some point. So when we're thinking about communicating with patients about their cannabis use, it can be really hard to navigate as a clinician. You're faced with not knowing enough information about cannabis, how effective it really is, but you're also pairing it with cancer survivors' own perception about their cannabis use. And also, where are they getting it from? Because as you've both mentioned, getting a medical marijuana card is really, really hard and can be expensive. But also, how do we not demonize cannabis in these conversations? There was a time when I went to my own survivorship team and they asked me about my substance use history. And at one point, I just started laughing a little bit because I'm interested in this area. when my clinician had asked me, "Are you vaping?" And so that was the point when I was laughing, and she full on laughing, and I thought it was because she wanted to follow my affect, but it wasn't really her responding to me like, "Yeah, young people nowadays, right?" And I was just like, if you're saying it this way, like if I did vape, I wouldn't feel comfortable sharing it with you. And so how do we not really like demonize cannabis in these kinds of situations? How do we make sure that for cancer survivors who choose to use cannabis, how do we encourage safe use of it? And so that's really my hope for my dissertation, to figure out how do we share it more like in these conversations.
I love that whole point of we need to make the uncomfortable comfortable, right? Because if we don't, then we're not going to talk about cannabis use, but we're also not going to talk about sexual health. We're not going to talk about financial toxicity. We're not going to talk about interpersonal violence, and they all impact how you access and receive cancer treatment. We are wrapping up the podcast. I'll leave just a little bit of space at the end. Anything that we left dangling threads, any additional thoughts in terms of, how do we improve this conversation in this world in which it seems like everyone and their brother is using CBD oil for something?
I think it's been a great conversation. I think Joy's point's really important about the open lines of communication. I always tell patients this is a no judgment zone. I'm here to help you, and the best way I can help you is to know as much about you as possible and what medications you may be taking, what are you eating, how's your mental health, everything. The more I can know you, then the better I can be prepared to help you and care for you. All these points are incredibly well taken, and I think this has been a great conversation. I know I learned a lot today, so thank you.
Yeah, and I'm very excited for all the work that's about to come out about cannabis as well.
Absolutely. Well, thank you both so much for this wonderful conversation. Many thanks to Dr. Pawlik and soon to be Dr. Tan, as well as our listeners. You will find the links to the papers that we discussed in the transcript of this episode. If you value the insights that you hear on the JCO-OP Put Into Practice podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts. I hope that you will join us next month for Put Into Practice's next episode. Until then, please stay safe.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.